Okay. Hello, I am Alexis Smith, and I'm the International Partnerships and Programs Coordinator. And thank you so much for joining us for today's Foundations of Global Health presentation. Global health is a varied and exciting field to which many healthcare providers, researchers, and faculty aspire to being professionally engaged. With our being a globally connected world, and with COVID-19 uniting the world to solve an issue, global health has never been more relevant. This year-long programming is designed to feature our experts in the field of global health, KUMC's faculty, researchers, and clinicians, our international partners, and our community partners. Each presenter will share their personal journey, educational background, mentors, books and articles that gave inspiration, challenges, lessons learned, successes, epiphanies, life-changing moments, and the heartbreaks. We do have some objectives for our series. The learner will gain foundational information on pathways into global health and will be challenged to deepen knowledge on equality and mutualism, which garners true collaboration and global health exchange for everyone's equal benefit. The learner will examine existing attitudes around global health so that we at the University of Kansas Medical Center are trendsetters who move beyond the us versus them, haves versus have-not mentality. The learner will be able to appraise global health, including global health research, philosophy, approaches, attitudes, and the varied efforts in the areas of health disparities, health inequities, and community health. Our next presentation will be in 2022. We are working on the schedule, but look for an email update from me. And now I'm turning it over to Kimberly.
Hello and welcome. I'm Kimberly Conley, and I'm the Senior International Officer for the University of Kansas Medical Center, as well as the Director of the Office of International Programs. And we serve all three campuses for here at KUMC. I'm going to introduce our speaker for today, Ms. May Maloba. May was here just a week ago at KUMC. I feel like we've just been so gifted with her presence. We had a small delegation from Cambrie that came to KUMC during International Education Week, hosted by Dr. Sarah Kessler, and May was among the few that came. So we're just really fortunate to get to interface and interact with May so much in these just such a short period of time. So May Maloba is a Kenyan and trained registered nurse with a master's degree in community health and development, with specialized training in maternal and child health care, reproductive, currently studying for a PhD with the University of Kansas, system strengthening. She also has vast experience in clinical research, project implementation, and management health. May Maloba is currently the Regional Director for Global Health Innovations, GHI, working collaboratively with Dr. Sarah Kessler, Associate Professor, and the PI for the Kenya-Tanzania project. She also works with Dr. Natabana Mabachi and International Global Health Program. May's nursing and public health expertise and experience serving in regional and country level positions to promote primary and secondary prevention programs, particularly in rural communities, and collaboration with governmental institutions, non-government organizations, and research teams demonstrates impressive skills she brings to global health teams. May has peer-reviewed over 35 articles. And in addition, May serves as our main contact in Kenya for resident and student international education experiences, like clinical rotations and research projects. So with that, I would like to have May take over for today.
Thank you. Thank you, Kimberly. I will start. Okay. Good morning, everyone. Thank you for coming, and I'm honored to be your presenter today to talk about Kenya KUMC collaboration, which is very important, especially for the students who are coming in. So we are going to talk about the work we are doing and the many universities that we are collaborating with, and the opportunities for you to join us. And thank you so much. And I'm happy to see Dr. Sarah Kessler, who will chime in case of anything. So the first picture you're seeing, this is one of the memorandum of understanding that we signed with the Kenya Medical Research Institute, Nairobi.
May?
Yes.
We're not seeing the slides. I'm not sure if you have them to share or.
Okay. Okay. Sorry.
Thank you.
Thank you. Okay.
Alexa, are you sharing or is May sharing? Had you sent the PowerPoint to Alexa?
Yes,
May?
I did. Yes, I did.
Okay, then Alexa should be sharing that.
Okay.
It was up a minute ago and it went down. Not sure why.
I thought May wanted to run her slides, but I will have it up in 2 seconds.
Okay, thank you.
Sure.
And then May, you just tell Alexa when you want it to be promoted.
Okay, thank you. Great. So Alexa, we can go to the next. This is just a Kenyan team. We can go to next. Thank you. So briefly, just to introduce Global Health Innovation goal, we are out to provide and strengthen comprehensive, coordinated and compassionate health services. And we started with the focus area of HIV. And right now we're expanding to other areas as need approaches. One of the things that we are doing, we are concentrating ourselves to electronic-based system as an innovation. We have designed it to meet critical health needs of the community, especially around the areas that we are operating. And we did this because of efficiency and to strengthen the health systems. So we also conduct social and clinical research, delivering high quality healthcare services and building capacity for healthcare providers. We also support exchange programs. And one of the things that we do, we work collaboratively with local universities and international partners. And one of the things that I want to mention is we have partnered with the biggest universities in Kenya, to mention Nairobi University. Moi University is the second to Nairobi University. And then we are also working closely with the Ministry of Health. So our focus area has been health system innovation, and this is where we started. We saw the needs of us improving the impact outcome for the early infant diagnosis, and it started in a unique way. So I'll just mention that we started by early infant diagnosis innovation, and then we went to PMTCT, prevention of mother to child transmission. From there, we saw our opportunity to support cervical cancer, and also right now we are doing COVID tracking system. And the reason why we did this is because when we started the initial innovation, it provided opportunities for expansion, and we saw the need to leverage what we have in order to cater for emerging needs. So, and this innovation is actually designed based on the impact, the demand. This is where we focus on what is the priority in the country and what are we improving globally. So that is what what drives our innovation. And then we look at sustainability. Here we are looking at involving and engaging all the stakeholders, including the service providers, the mothers themselves, and all the Ministry of Health at the leadership team hierarchy from the national to the facility level. So we are also looking at participation, because again, if you're doing an innovation yet you're not engaging everyone, then it becomes a challenge in terms of sustainability. Then we also support stakeholders in terms of training for public health leaders. This is because when you're doing innovation, you don't look at what is your need, but you also look at the needs of the facility. And we are striving, our goal and our aim was to strive to meet the UNAIDS 95 target. And this is specifically designed for prevention of mother-to-child transmission. So we work in partnership with local stakeholders to customize the system, ensuring that we meet the needs, the unique needs of the provider and the policymakers as well. So this is the outcome. We started by supporting early infant diagnosis. So the HIV infant tracking system is a web-based system that tracks the interventions of mother and connects the baby, all the stakeholders for accountability and improvement of care. And eventually it gives us the data that we need, because we realize that in resource limited setting, data and data system is still a challenge. So we came up with an efficient system that can actually support all the stakeholders in terms of where do they meet and how do they identify gaps. So you can see when we started the early infant diagnosis program or intervention, we had massive improvement in terms of the outcome. And we can look at the services. We had 6 sites where we had 3 intervention sites, 3 control sites, and then we measured the outcome and the impact. And one of the things that we want to applaud us is because when systems come, especially the electronic system, medical system, they're not tested. But over time, since 2013, we have tested and piloted all our innovation, and they have managed to scale to a scale of 5 years implementation. So we are looking at, when we started the early infant diagnosis, we were looking at infant, and we were looking at how they can be able to get results on time, timely management, and also the laboratory guys are able to communicate to the clinic providers. So when we did that, there were so many challenges where results were getting lost. Mothers were not informed about their results. This contributed to poor outcomes, like baby dying before they are initiated to care. So when we were doing feedback to the nurses and to the county health teams, they suggested that, why do you only follow the infant, yet the mothers were also having challenges? That is when now we went to opportunity 2, where we wanted to see, if we include the mothers, how will that innovation look like? And we realized that there was a need for us to have a longitudinal tracking tool. That is, now we went to support prevention of mother-to-child transmission. And we wanted, our main aim is to engage and retain mothers and ensure that their adherence throughout the services, and eventually achieving the elimination agenda. So you can see our focus area, or our key variable outcome that we were looking at. We had appointment to delivery to attendance. This is within 7 days. If a mother has been given appointment to come to the facility, how long will she take to come to the facility based on the provider's recommendation? And then we also look at facility delivery, because this is where we were having challenges, and most of the facilities still have challenges. And then we were looking at how to pair mother and baby immediately the HIV positive pregnant woman delivers. So you can see these are the results that we got for appointment attendance within less than 7 days. We had around for intervention site was 60.7% versus 28.3% standard of care. So you can see it was actually way below the 50, the average. Facility delivery, it was high at 92.9% versus standard of care 71.7%. And then you can see the linkage, which is very, very important. So for facility delivery, most of them, when we were having the technical working group, they really complained about HIV positive pregnant mothers delivering at home. But right now, the HIT system, the HIV infant tracking system, it provides us an opportunity of longitudinal tracking, where you can even account for how many mothers are getting the acquired or design intervention. So you can even say out of 100 mothers who I receive in the facility, how many do they achieve the 4th ANC attendance as standard? And how many do they come in to deliver at the facility? And how many babies continue to care until they are discharged or they are exited to care after they have tested negative at 18 months? So right now, the way our registers are fragmented. You can only talk about revisits. So when we are aggregating data, we will take all the new clients plus the revisits, and we cannot ascertain individualized best data. How are we performing? So the HIT system has that provision, and even it tells us if we have 100 mothers, and at the end of the day, we are having probably 10 mothers delivering, then we ask ourselves, where are the rest? So it gives us accountability for premature death, for preterm delivery, for loss to follow-up, and also even for people who decline care, and which is important for resource mobilization and even decision-making at the higher level. So the last table, it actually tells us the steps, the milestone that we took. So we started by the HIT system 1.0, where we started the whole initiative of attending this. And then you can see we were looking at HIV exposed infant, and then we were looking at efficiency of sample processing, ART initiation, those who turned positive, and retention to care at 18 months, then they were exited to care. Then we developed 2.0, where we were now including the pregnant mothers. And right now we are currently working on how we realize that we have challenges with the viral load. So that is now where we are now. The key intervention for the HIT system, we have dashboard alerts where providers are able to determine the missed opportunities. For example, number not tested, number needs intervention or follow-up. They will just open the dashboard and then they will be given real-time performance in terms of the services that they have. And the key focus area, I've mentioned that, but we look at the guidelines. What is the guideline saying? So if the outcome is the testing, all the testing will be at the dashboard, all the appointments, delivery alerts, all of them will be at the dashboard. We have SMS reminders for adherence support, hospital delivery, and just encouraging the mothers to remember to come back to the facility for their test, or to come back to the facility so that they can receive the necessary intervention. And then there's a linkage to early infant diagnosis. So we are pairing the baby and mother, and also we are looking at enhanced viral load monitoring, because there's no need for us to say we are monitoring the uptake for ART, yet we cannot be able to measure that, because the essence of us giving ART is to ensure that there is improvement in terms of patient outcome. And that's why we have that. And also we have watch lists that most of the time it gives us alert for data quality issues, completeness, and easy follow-up. Next. Thank you. So after we did the first and the second PMTCT, early infant diagnosis and viral load, we saw the opportunities of doing this to cervical cancer, because we, even our registers still right now, we are still having fragmented data, and loss to follow-up are so high. So, and right now, the UNAIDS have given us a target to accelerate plan towards cervical cancer elimination. And we thought our HIT system can be designed as well to fit what is needed. And what we are looking at is cervical cancer screening and diagnosis. We looked at cryotherapy, treatment administration, linking to various timely linkage to other department for treatment. So, and that can actually give us also the same results as the PMTCT. So this is just specifically showing you the dashboard, what we were looking at, starting from the counseling, the treatment outcome, the testing outcome. And these are very, very key in terms of cervical cancer control, so that we can be able to ensure that people get timely treatment and management. One of the our collaborators, major collaborators, are Cambrie Medical Research Institute, and they have 39 years since they were flagged as a national body responsible to carry out research. And the reason why we are working with this government is because they are the controlling government to all the research that are done in Kenya. So any research that are coming from Kenya, from Cambrie, it's also it's determined as prestigious research. The other thing that we are doing with them is doing the exchange program. So far, we've had several doctors coming and students, and also because of our partnership, we have two students, me included, getting enrolled to PhD at the University of Kansas. The other thing that we need to know also about this exciting collaboration is any study, any challenges that we have in research, we always come back to Kenya. They will start with Kenya because they will start with Cambrie because it is the research body, and then they will go back to the small studies. So they always collaborate with CDC for any studies they want to collaborate with. We also have Moi University collaboration. This was founded in 1984. It is the second to University of Nairobi. And one of the interesting outcome we have is an online class exchange program led by Dr. Michelle Crocken. And this is very interesting because, you know, we are used to physical exchange program, but quickly because of the passion of doing something different, this particular collaboration partnership was initiated, and they are having the second class coming in next year. So already they have shared assignment. They're talking about many other opportunities that they will work together to ensure probably exchange collaboration works online. I'll talk about next. So we also have Nairobi University, and also this is also another, so this is the first biggest university. And between Moi University and Nairobi University, we get our students there. They have all the subjects. They do medical, they do nursing, they do community social work, and all research that they are done here in Kenya. And also they have other collaborative projects that we can benefit from. We are working with our network in KUMC. We not only work with Department of Family Med, but we also look for other partners within the university that we can work with. And one of the study that we have assessing caregiver and child preference for development of novel pediatric ART delivery, we are including Dr. Edward Melikski and also Dr. Gregory Thomas for our design. So we have more opportunities even for students who are interested in collaborating with us, just to look at what interests them in terms of data collection, in terms of area of interest, and even just networking with other students around here. So this is our Kenya research team and Tanzania research team. And when I was taking these slides, I actually looked, and interestingly, I was asking myself, they were actually looking at the resources that we have around here, because they would have gotten anywhere. So we have coast. Coast is in where we have the Indian Ocean, and then we have at the Lake Victoria. That is where we have another research where President Obama's mother is. And we have Tanzania, Mbeya, where we have many interesting collaboration as well. We have universities. We also have institutions that we can collaborate again with. So this is an interesting picture that shows you more sites. In Kenya, we work with almost 20 counties that we have a very good relationship with. And these counties, they also have different cultures, different way of leadership. And when we go there, when we are doing our collaboration, already we know their area of interest, because even the disease pattern varies. So you can find, like in Kapsabet, where this picture was taken, we have nomads, many nomad population, where you'll see a different patterns of infection. TB is more on that region. Nairobi area, we have more. Nakuru, we have different ailments with different culture. So one thing I want to talk about is culture. When most people who come international for international visits, they are always humbled by the way we approach things in terms of treatment, who is conducting treatment, and how do we collaborate with other people. And one of the things I want to applaud for Kenya, not because I come from Kenya, but because of the culture. So the culture is the reception to visitors. Like Professor Dean Akidiom, when he was here, he was made a chief. Because when he came, they saw more opportunities of collaboration. And when he came and talked about the respiratory program, everybody was excited about it. And they were so receptive, and they wanted to even go to the community, make him a chief, because that means, they were so intelligent, because they wanted him to stick here. But one of the most important thing is language is never a barrier, because our Kenyan system, they use a standard English right before any time someone goes to school. So, and the other thing is the culture different. At other site, before people are dispatched to their clinical areas, we have to talk about some of the things that can be a barrier. But most of the time, I think working here, and even Dr. Sarah Kessler and Nati coming back and forth, they've realized they've not had any barriers in terms of just interacting with other providers and even patients. So we have a standardized way approaching any challenges, and also just being receptive and just merging with the existing team. And the culture is just to listen, to learn, and then say, okay, how do we work differently? And by the end of the visit, many people, when you come back, or many people are usually feeling so sad that people are leaving. So this is, apart from just learning and learning and seeing how things are done differently, especially probably in delivery, we have a lot of things that are so different, especially the programs, school programs. We have how patients are treated, and how we approach the research. And after everything, because it's always like you run and you do not rest, because they will want to see you most of the time at the clinical areas. So before the end of the trip, we always want people to now enjoy the scenery, where they can just take a breath, reflect. And one of the things we have to applaud ourselves is we have nature trail. We have very good parks. One of the parks is Hell's Gate. And Hell's Gate, we have a very famous Tomb Raider, where a movie that called Tomb Raider was done. And these are always very safe places. They have very good historical patterns. So these are the places where we will want to take our visitors when they come. Lake Nakuru is just a 1 hour drive from Naivasha. And this is where you find unique animals. Like, for example, white rhinos. You can find them in Lake Nakuru. You have flamingos. You can find them also in Lake Nakuru. The other thing that it's very interesting and exciting is when you just have a drive very early in the morning, you can also just at the road, you can just see the animals going after, they're going to to drink their water and coming in. So it's a very exciting place also for people to just relax and just meditate on what they have learned. Karura Forest and Two Rivers, a place where we feel like if people come and they want to observe nature and do hiking, this is also a place where we think that we can take students, and many people have been excited to go here. And this is one of the sites that we want to explore. So from publications, you can see, we just did this because we wanted people to see at the end of the day, if anyone is interested in publication, if anyone is interested to join us in any other studies, because all our research studies, our data, we do more of qualitative work and quantitative work. And these are areas where we can collaborate. Dr. Kessler is always available to attach many students to help us in any work that we have. And also when you come down in Kenya, this is where you can visit our sites. We have, right now we are operating within 12 sites, 8 sites in Siaya and 2 sites and 4 sites in Coast. And this is where you can just come and also just walk around to see how we can support each other. So we have other people that we collaborate with, and these are our partners. Thank you.
Thank you so much, May. We really appreciate all that information and that great overview of the work you're doing in Kenya and all the great partnerships. And I think that's one of the really important aspects that we like to highlight when we talk about global health, is the importance of the relationships and the collaborations, and how important it is to have a network of individuals. And you so clearly show that network and how expansive it is. I also appreciate how much you and Dr. Kessler have really institutionalized these relationships, so it's not just dependent upon one person, but it expands to institutions, all of KUMC, Moy, Nairobi University, Cambrie, etc. We have a few questions, May, so I'd like to start with just kind of a basic one. Can you tell us a little bit more about yourself personally? Like, what was your path? And like, when did you know that you wanted to have a career in healthcare? And then when did that decision change to a career in global health?
Thank you, Kimberly. So when I went to my nursing school, I think that is where I can start, is I was really interested or excited to do work that is not really exciting to other people. So for example, when you see, that is the time when I was doing, that was 1999. That is the time we had HIV. And that is, you can imagine how COVID is treated now, like the stigma that we have. That time we had HIV highlighted, like, you are not supposed to come close to this person. It was really, really exaggerated. So people would run, in fact, will not even, anytime someone was diagnosed with HIV, no student will want to sit around this person. And that made me more excited because I was doing something unique that people don't want. The other thing was I was more of taking care of patients' needs, especially, when you have a very chronic ill patient and she needs bed bath, she needs, she just needs someone to be constantly there, like a one-on-one nursing care. And because we are so many, we are so busy, sometimes people would assume and they would leave people who are very needy and they will go to people who, they're well off. So those are the things that I really appreciated. And I appreciated to see one patient coming in as very ill and just discharging this person smiling. So when I finished my nursing school, I went to start my my outpatient department, and here I think people just saw my skills. The way I was just I continued growing to love the things that people did not love and appreciate, and I thought that those were very, very important. So I didn't know then that I was going to fall into research. But one time we had post-election violence and I was posted to a place where there's no, I didn't have a job. And the only opportunity was male circumcision. Then they asked me, May, do you want a job? I said, yes. Would you love to do male circumcision? I have never done it before. And I was like, I cannot do circumcision for infants. So that is what came to my mind. And I said, even if I want job, I cannot do this. I've not done it before. And I don't think that I would be excited to do it. Then because I had so strong background with reproductive health, then that is when it opened up my avenue to cervical cancer. And this was 2007. So for 2007, this area, cervical cancer, was not really appreciated. It was never a priority. And it was just done by donor everywhere. I think we were only 3 partners that were supporting cervical cancer in the whole country. And it was really fragmented. And the government did not want even to hear about it. In fact, even PEPFAR, right, the bigger donors, the HIV donors, they did not want even to hear about, they were really biased to HIV. If you tell them, oh, we have even data for cervical cancer, they will not look at it because it was not a priority then. So we continued doing this, and it was very exciting because when we started finding data, everybody came in because it started now becoming priority around 2012, 2012, 2013, that is when now we started doing the policies. And surprisingly, I was the only one who had the data. So they had to come, and the fact that they did not support us, the fact that they did not support cancer, that is where they came to find data. And just we started with one study that really came out to give birth to many studies, like 6 studies within embedded with one big study. And that is when we started this. And we started this exchange program with University of San Francisco. And when students will come to just the cervical cancer room, we called it reproductive health room, they even changed their career. And I thought that that was very touching, and it was very new. And to a point that I felt that when they were exposed here, they saw the needs of women. They learned so many things, how we operated with limited resources. They saw how we took care of patients. We did not wait for the doctor to come. They saw many women with needs, because, you know, I was working in a clinic where 10,000 HIV women were enrolled to care. So many women were coming because we started doing this as a screening program. So that is now what diverted and shifted my career. So the work with cancer became more, and then the interest with children now came in, because now I couldn't separate mothers with children just the way we did with the HIT system. And the passion for reproductive health grew, because when we were doing screening, we not only did screening for cervical cancer, but we did screening for other reproductive health challenges, because initially, women will come in and we will just ask them a standard protocol. What are your needs today? How are you feeling today? And then they're prescribed medication. But when they came in for screening, routine screening, then you would notice other challenges that they did not know about. And that is when now we came in for treatment. People would just come in, they want drugs, but they had other challenges. So that is how my passion grew. And that is how now my opportunity for expansion to international partners started in. And that is when now we started in to work with other Ministry of Health personnel and officers, because we needed now to start scaling our project. So we started with 2 projects, and then we expanded to 75 facilities. And here, we needed to have, just the way you said, public relations is key to everything. For your sustainability of project, for building up relationship, because, you know, you'll be moving back and forth. And you will be taking these people as, you know, everyone that you work with as family. So anytime you have challenges or conflict, there's a way that you have to approach it so that you can be able to resolve it well. Because maintaining 75 sites is not easy if you don't have good interpersonal relationship. And the other lesson that I learned during my scale-up project before I joined my beloved now, Dr. Kessler, was conflict resolution is very key, public relationship, and how you tie what you need to do with the existing priority. Like, for example, if you want to do a research, you have to look at what is the country's goal, what is the goal, what is the impact, because at the end of the day is the impact with the community. And how you also communicate to your clients matters a lot, because they spread words. Your project can be accepted or rejected based on how you handle clients. So this made us, you know, have a way of, even if, you know, sometimes if you have limited funding, you don't have money to distribute to people. So your PR and your relationship is the one that will build people. People will not come in because of money, but people will come in because of knowledge that you have impacted. People will come in because they know that there's need, and they will be able to support other people because they will say, oh, let's go there. So many people will come in and disclose many things because you have built trust. So trust is very important. building relationship with the at every level, because we now started at the national level. We went down to county level, and then at the facility level. So all the levels are very, very important in terms of building relationship. And then cultural acceptability. Because I'm from the different culture, I have to learn the culture of the other so that we learn from each other. We don't compete, but we become friends. We become people that we can work together to achieve one goal. So instead of competing, we complement each other.
Oh, that's so well said, May. All of everything, and I'm reminded of the quote by Robert Frost that says, "I took the road less traveled, and that has made all the difference." And you really did choose the road, the path less traveled, and you have made, such an incredible difference, not just with, your teams and the people you've drawn to the project because of your enthusiasm, but also all the patients, all the women that you've served over the years and really helped to provide better care and better research around that care. Very, very impressive. And I'm always just so happy to share your beautiful heart and all of your passion. We do have another question in the chat, and it came from, let's see, I think it was David, and he said that your work is awesome, and he was wondering where the HIT system was mostly utilized. It sounded like you were in some of the major towns, but he was also wondering, did you do both urban and rural usage of the HIT system for your research? And I know Dr. Sarah Kessler, this is your research project, so both of you can talk about that if you'd like.
I wanted to hear her voice.
Okay.
But so and I know she will talk before, because she's a family, she's a Kenyan family. When she comes, everybody wants to, she's never forgotten. So when we are doing a selection of site, we choose both urban and rural so that we can be able to see the outcome, because there's different in acceptability, there is different in volume. Like our study was following where the HIV is. So, and also long-standing relationship where we have built trust, and also where we have patients, and where we can say, oh, this is where we can get our data. So both rural and urban.
And he also, David, wanted to know what were some of the challenges that you experienced, and were they different, were the urban challenges different than like the rural challenges, for example?
Yes, they were different. They were different in terms of policy dissemination. And one of the things we realized that there are facilities, especially in the urban area, that will adapt quickly to the guidelines as opposed to the rural area. And then in terms of engagement, you will find that the patient barrier, like for example, when you want to set up your research, like for example, we did set up a point of care at birth testing. And one of the things we realized, there's difference in setting up of the facility. So you'll get a facility that is well integrated within one building, but we have another one that is not integrated in one building. So in those kind of cases, infrastructural differences, we had to modify many things in terms of our budget. And also how you deal with people at cost. And people will always tell us, and they will say, people at cost, then they're different in terms of the expectations. So also that we realize that that is a cultural barrier. So we don't treat them the same. We go here, the way you're received here, the way they will give you ideas. And it is so beautiful, because how they will handle things this other side is different from the rural area. And we as a team, we will come together and adapt each other. Like we will say, oh, How are you performing? These people are working this way. Can we adapt this? So it helped us modify many things together. Sarah can chime in.
Yeah, thank you, May. This is so nice to have you speaking to our KUMC community here, which is also your community as well. And I just want to take a minute and say a little bit about what a gift it's been for me to partner with May. As May knows, I've had some stumbles and growing pains myself as being a researcher working in another country, and certainly experienced my share across the gamut of gender-related challenges in that work. And so I just feel like for me, my life and my whole spirit and energy towards this work has just been so blessed by having the partnership with May and working with such a capable and gracious person who I say is really my mentor in relationship building, because May can walk in. I mean, when you see these cards stacked against you and you think to yourself, how will we ever find consensus in this situation? I am just amazed at how May's combination of her personality and I think humility and humor and just desire to see the best and the optimism of what could be has really taken us from some challenging spots and found light and hope that's really grown and fostered into something I know we're all very proud of, the work and the relationships of the team. So I just wanted to sing her praises as my Kenyan sister and partner in this work, and share what a capable and fantastic partner she is.
I think that also is just great advice, Dr. Kessler. It kind of speaks to needing someone within the culture that understands the culture to be your mentor. And what a gift that is in terms of being able to navigate the culture, the expectations and issues. We do have one last question. Grace, feel free to take off your, unmute yourself if you'd like to ask your question yourself or anybody else. We do have a small time constraint because Alexa has to be somewhere right at 12, but we have time for your question, Grace, if you go ahead and ask.
Yeah, of course. First of all, this presentation was so amazing, and I appreciate all of the work that you guys are doing. And my question is just how, I'm a second-year medical student, and I was just wondering how myself and other medical students could possibly get involved with research or any other global health fields, and if you have any advice for us.
I love that question because that's exactly why we're doing Foundations of Global Health. But go ahead, Dr. Kessler, please, and May.
Yeah, well, I'll just briefly say, Grace, of course, you're connected with OIP. I mean, we're so lucky at our institution to have such a fantastic team that's always looking for new opportunities and ways to really support students and getting involved. And so if you haven't already, really go and pick the brains and spend some time sitting with our great OIP team. If you're interested in being involved in some levels of research, or maybe having a chance to see if there's some qualitative data or quantitative data, or maybe just doing background literature review searches that could contribute to either a grant or a paper, I always welcome students to come to me if you have your interest somewhere in the realm of women's health, HIV, now some COVID-related work. We also have some great faculty at the institution who are doing projects in other parts of the country that Kimberly and team can connect you with. But I think you just have to take one little step and then the next, because as you do, more opportunities will open up. And then, of course, with our program for IEEs, really start strategizing early. I missed it if you said which year you are, but so that you can really make a second year. Okay, so you got time to make it happen for your M4 year. And we have our virtual. We also have some opportunities now for sort of virtual global health IEEs that are fantastic, as well as the more traditional in person. May, do you want to add something?
No, I think you've said it all. The other thing I wanted to say about the impact, when people come here, what I've learned is a change of attitude. They modify, even changing careers because of how they see people being handled and how people are very receptive and patients being taken care of.
Fantastic.
Thank you guys both. That is very helpful and insightful.
With that, we'd like to thank everyone for attending. I think we all can agree that May is a wonderful presenter. She has an incredible voice alone. She's gifted in many ways, but I love listening to May. I can listen to her all day long. So it's always a pleasure. And we have this recorded, so you can access it. Plus we can also share it out to other students. And please, if you want to make contact, the purpose of Foundations of Global Health is to connect our community. So if something interested you, feel free. We can connect you with May. We can connect you with Dr. Kessler. And we obviously want you to connect with us. So thank you so much. We wish you the best. A wonderful Thursday, sunny day in Kansas City in May. I hope you have a great night in Kenya.
Thank you so much.
Thank you.